Good evening, doctors. First of all, on behalf of Ajanta, let me welcome all the medical fraternities from across India and for attending the scientific session on the topic of telemedications during and after COVID-19 pandemic. I know, sir, this is the topic which is very crucial in the current situations, and this will be very helpful for your patients for treating on the telemedications. And Ajanta Pharma is also grateful to have an eminent speaker, Dr. Nilanjan Sengupta, with us now from Kolkata. And Dr. Nilanjan Sengupta, if I talk about his credentials, he is a professor and head of Endocrinology Department, NRS Medical College, Kolkata. He is also Vice President, Diabetic Association of India, West Bengal. He is also a Joint Secretary with Endocrine Society of Bengal. He is also a member of Governing Council Endocrine Society of India, West Bengal chapter. List is not stop here about his achievements and credentials. It will be long, but I will not going to take much of time. I will hand over this entire sessions to Dr. Nilanjan Sengupta, who is from Kolkata. Over to you, sir. Please take this session over to you.
Thank you, Vasant. Thanks, Ajanta, for organizing this webinar. And the topic is very relevant on telemedicine. Right, I need to see the screen. How do I get to see the screen? So what is telemedicine? We all know what telemedicine is. That is when you actually give any advice to any of our patients by way of a medium, a communication medium, other than a direct physical interaction. So that may be via telephone, that may be via WhatsApp, via any other messengers, probably not a letter. Today nobody writes a letter, by way of video conferencing, whatever modality you use, so that you can understand. So we all have been doing this in the past, a little or more, or somebody didn't do it. But now when we are locked down and this is the era of physical distancing, and I'm afraid this era of physical distancing is going to stay for quite a few months at least in the foreseeable future. We are now thinking of telemedicine, and that has got the definition by WHO, and that's on your screen. The delivery of healthcare services where distance is a critical factor by all healthcare professionals using information and communication technologies for the exchange of valid information for diagnosis, treatment, and prevention of disease and injuries, research and evaluation, and for the continuing education of healthcare providers. So this session that I am doing with you also falls under the purview of telemedicine, all in the interests of advancing the health of individuals and their communities. So this is a descriptive definition. You can well understand what it means, but rather than the definition, I think we all can perceive what telemedicine is. Now, a little bit about the history. The first idea of telemedicine, as we know today, appeared in 1924 in the issue of Radio News magazine. The magazine depicted using television and microphone for a patient to communicate with a doctor, including use of heartbeat and temperature indicators. That is for those who are interested in the history. But from April 1924 to, I think, March 2020, nobody in India at least did take telemedicine to be of so supreme importance, which it was kept as an alternative. I, for myself, was actually averse against any form of teleconsultation. I didn't encourage any form of telephonic conversation. or any form of communication with the patients by way of WhatsApp, email, and so on a day-to-day basis. On an exceptional basis, I used to encourage that. But because of the coronavirus pandemic, the world is changing, or the world has radically changed in such a way overnight that what was thought as a poor alternative in the past is probably turning out to be the only viable option, only safe option for communicating with our patients, either way, for the healthcare providers communicating with their patients, or for the patients communicating with their healthcare providers. So another term, telehealth, has been uh, used, and we need to differentiate telehealth from telemedicine. Again, I think we need not go too much about the definitions and nitty-gritties. Again, I reiterate, we understand what telemedicine is. Now, how can you apply telemedicine? I think that again is a technological question, because telemedicine tools may be many, and depending upon the technology, it can be telephone, it can be videos, it can be devices connected over LAN. What is WAN? I also do not know. Internet, mobile. So what is important is the second bulleted point here. Irrespective of the tool of communication used, the core principles of telemedicine practice remain the same. The core advantages remain the same. The core disadvantages remain the same. But having said that, if we conceive of telemedicine, I don't know those who are in the audience whether they have actually started uh, formally telemedicine in right earnest with in their practice or not. I didn't know. I haven't started yet, though. Yeah, I'm giving a serious thought of doing it. Means is a formal telemedicine, but apart from that, all of us in some form or the other have communicated with patients in times of their emergencies by way of a telephone call. That is the commonest mode of communication with the patients, and I'm sure all of you have done without ever having cared to know about the definition of telemedicine as has been propounded by WHO. All of you have attended even webinars, though webinars were not that frequent in the pre-COVID era than what it is now. Maybe you have attended webinars at the rate of one webinar per month. Now you are attending around 4 webinars per day. So that frequency has only increased, but then webinars were also there. And of course, some of you have definitely used the email and text messages or WhatsApp after WhatsApp has been made available to us in communicating with our patients. So telemedicine applications can be classified into 4 basic types according to the mode of communication, the timing of information transmitted, the purpose of the conversation, and the interaction between the individuals involved. So as I said, it can be video, like the platform that we are using today. It can be audio alone, and the commonest example and the most frequently used example is probably the telephone. Text-based, as I've said, the commonest may be chat-based, be it simple SMS chat or WhatsApp chat or even Facebook Messenger. Whatever messenger you use, it remains the same. Or it can be asynchronous, that as you have said, that is email, fax, or in the yesteryears it may have also been the mail, surface mail, but nowadays surface mail is all but dead. I think it's only for legal purposes. So it's basically the email or the fax. So what are the two differences between the real-time one and the asynchronous one? Real-time, as this program that we are doing is a real-time one, video, audio, or text for exchange of relevant information on a real-time basis. That is, on a video chat, you are chatting with the patient. So that is nearest replacement to a physical one-to-one conversation. And asynchronous, mainly email or fax, that is transmission of summary of patient complaints and supplementary data, including images, lab reports, and or radiological investigations between the stakeholders. Such data can be forwarded to different parties also, like if you have a WhatsApp message, WhatsApp picture of a X-ray or a CT scan or an MRI, and the patient sends it to you, and you do not understand the exact nature of the radiological investigation, you can forward that investigation to your radiologist colleague for him or her to look at it and give her or his expert opinion. And that can be assessed at the real point of time or thereafter as per convenience or need. Now, according to the purpose of consultation, it may be the first consultation and the follow-up. So that is nothing more about it. But the point is that if now we are using a telemedicine platform for consultation for a naive patient, we have to be very much alert and conscious. First, because you haven't seen the patient physically, you have to test the veracity of whatever is being presented to you, number one. And number two, since if you have been seeing a patient for a long time, and if you have a clinical idea of that patient, which happens to us, if we have a patient who is following up regularly for, say, last 6 months, when for the 7th visit, the patient makes a teleconsultation or video consultation, the thing becomes much easier for us as a healthcare provider to understand the patient's clinical status until and unless something exotic has happened, and therefore ordering things should be easier. But if you are doing to a naive patient, the healthcare provider should be doubly cautious. Emergency consult for immediate assistance of first aid. I think what I will say here, it will sound like an oxymoron. For emergency, telemedicine is the best because it can be lightning fast. For emergency, telemedicine is worthless. So depending upon the emergency that you are facing with. For example, if a patient of diabetes on insulin, the patient lands up into hypoglycemia. If the patient calls you up and tells that the patient has skipped his breakfast because of nausea or something, had taken the insulin, now falls unconscious, you can say that, okay, don't worry, probably the patient has gone into hypoglycemia. If the patient is conscious, give him some glucose to drink. If the patient is unconscious, rush him to the nearest hospital emergency, who will give the patient glucose, and thus the patient's life will be saved. So whereas the patient's life could have been in real danger had the patient had to wait for 4 hours before reaching you physically and you diagnose the hypoglycemia and treat it, it's over phone. You can treat the you can actually understand the hypoglycemia, give the advice to the patient, and thus remotely treat the patient. On the other hand, suppose a patient of diabetes suddenly suffers from an acute excruciating chest pain. There, up to a certain extent, telemedicine would help. Maybe the patient has suffered an acute coronary syndrome where probably detailed evaluation or even thrombolysis would be necessary to save the patient's life. So the initial consultation with, via telephone or a video chat that the patient is serious and rush him to the nearest hospital emergency, that part of advice via telemedicine is very useful, but the latter part, I'm afraid, cannot be done by way of any sort of remote telemedicine. The patient has to reach to a healthcare provider. But that's what I want to say. At times, we view telemedicine to be a substitute for, as a replacement for physical consultation, which I think is the norm or order because of the lockdown. But at times, a telemedicine can act as a supplement to, not as a substitute for, a proper physical direct contact medicine. So according to the individuals involved, how the connections may be done. That's obvious for you. The patient can directly contact the doctor or the physician. The caregiver of the patient can connect the doctor, but always, if possible, try, insist that the patient connects with you, because if it is the patient's problem, the patient would be the best person to relate his or her problem if he or she is in a position to actually relate. But if for some reason the patient is too unwell to connect with you directly, or the patient is a child or is not mentally stable, then of course you have to take help, or is very ill, you have to take help of the informants like the caregiver and the close relations. Then of course can be a doctor to doctor. Even you can have a teleconferencing in some situations where that helps. And another thing is a health worker to RMP, or the other way round, or the health worker or a supporting staff, because in our practice, we have to work with diabetes educators. What I tell in most of the instances, when I put a patient on insulin, the first thing what I do, I give the number of my diabetes educator to the patients. And I ask my diabetes educator, there are a couple of them, to actually interact with the patients on a regular basis. And I also ask the patients to keep my diabetes educators updated on a regular basis. In around 30 to 40% of the situations, the diabetes educator himself or herself can give adequate advice to the patient, manage the patient with advice on adjusting the insulin dosages, or even manage a hypoglycemia by means of telemedicine. If he or she fails, then he refers the case to me. Maybe a glucose monitoring chart is sent. I ask my patients to send the SMBG log, or the glucose monitoring chart, along with the dosage of insulin that the patient is on, to my diabetes educator. The diabetes educator looks at the chart mostly by WhatsApp and advises accordingly. When he fails, or it is beyond his knowledge, then he forwards the WhatsApp to me and seeks my advice. In turn, I give my advice to be communicated to the patient via my diabetes educator. What has the advantage? How that is advantageous? First, that the diabetes educator shares a lot of my burden. Number two, that saves me a lot of time, because if I have, say, 7 patients in one day for the follow-up of blood sugar control, this will take much more time. Whereas my diabetes educators, who are actually dedicated for that, they do it. Out of the 7 patients, maybe 4 or 5 patients they themselves can manage and just inform me that I have done this. And for the rest too, he refers the cases to me for expert advice. So that's why it's a very good symbiotic relationship involving the patient or the or patient's caregiver, the diabetes educator, and the healthcare IM and the doctor, all bound together in a loop or a circle through telemedicine platform. So again, the modes of communication we have talked. Now, strengths and limitations of various modes. Of course, none is perfect. Everything will have its share of advantages. Everything will have its share of disadvantages. So the video is closest, as I've said, the video chat would be closest to an in-person consult rather than the patient. Rather than the physician, here the patient has a feeling that the patient is as if talking to the doctor. As I'm addressing you as an audience, I'm missing out something. You probably are being able to see me. So how do I look like? How do I talk like? What I'm wearing? Because you would be curious because I am presenting to you. Many of you know me. Many of you may not be knowing me, but at least you are hearing. Thank you for that. You are listening to me. You are hearing from me, but at least you have the right to know how do I look like? How do I speak? So that is possible in a video chat like this. So just imagine the patient. When the patient is talking to the doctor, especially if the doctor is not known to the patient beforehand, the patient would like to see him, how he speaks, how he looks like, how he behaves, just as the patient doctor would also like to see the patient, how he appears. So, and for us, you can well understand if the patient has a facial edema. So if the patient has a facial cellulitis, if the patient has a sore and ulcer in the leg, that you can at least see through video conferencing. Though I do admit this is only a poor substitute to a direct physical inspection or a physical examination, but still it's better than nothing. But you can at least inspect, though you cannot palpate, auscultate, or do other things over a video chat, but at least you can see the patient to a limited extent, and also the patient is able to see the doctor to a limited extent. So this is closest to an in-person consult. But the greatest limitation is that if I start this video consulting, I'm having a Wi-Fi connection, I'm having a robust internet connection, I'm having a laptop, I'm having a desktop, but for the patient also to participate in that video conferencing, the patient should have that technological support in hand. And still in a so big a country like India, with so much of economic disparities, and especially in rural areas, problems of power and problems of internet connectivity, you cannot expect that each and every patient will be able to have the infrastructure, both the physical infrastructure and the internet bandwidth, to be able to participate in any form of video conferencing. So you have to understand how much good and ideal video conferencing is. It may not be practically executable when it comes to many of our patients. Next, so comes audio, that is phone, apps, so on. So let's concentrate on the telephone, because I think because of the telecommunication revolution in India, I think everybody probably is now having at least a mobile phone with a free call connection. So that is no longer a problem, even in rural area or even in the most interior parts of India. Which was unthinkable maybe about 3 decades back, but that has been made possible. So with that, it is convenient and fast, and therefore it has an unlimited reach. Because whereas video consultation may still be restricted in its reach, teleconsultation will have an unlimited reach, because telecommunication, so far as telephone is concerned, has become quite efficient in India. As I said, it is suitable for urgent cases. Suppose the patient at, say, 12 midnight suddenly has an emergency, has hypoglycemia. Now, if you want for if you ask for a video consultation, what you'll have to do, you have to go online, switch on the video, and do everything, and then start talking with the doctor, which itself may take about 15 minutes or maybe at least 5-7 minutes. For preparing this video conference, I also had taken about 15 minutes to be online. Whereas if you do a phone consultation, you just pick up the phone, dial the doctor's number, and talk to him. It is as simple, as easy, and as unlimited in reach. It doesn't require any special infrastructure. It's a real-time interaction. The limitations, first thing is that generally speaking, the doctors do not record the patient's voice in phone, so it doesn't have a record. But second thing is that suppose the patient is telling over phone about a blood report. The patient may commit mistake. The patient is not a medically qualified person in most of the cases. The patient may not understand the medical terms and the figures. And suppose the blood sugar is 310 and the patient reads it as 110, or if the patient blood sugar is 310 and the patient says it is 310 milligram percent, but the doctor listens it is 110. So you actually may be led into misdiagnosing or making errors of judgment. So I think whenever it pertains to any blood reports, I always insist, well, I'm talking to you over phone, but prior to that, you send me your reports over WhatsApp. I see the reports and then I talk to you. So the point is that, and second, it doesn't have any record. Maybe say over phone, you tell the patient you take so and so tablets. Suppose you say you increase the dose of insulin from 10 units to 14 units. The patient hears or interprets or listens, whatever, you decrease the dose of insulin from 10 units to 4 units, and the blood sugar goes up. And next, at the next visit, the patient may accuse you, doctor, you have changed the dose, and now my blood sugar has gone up. Where in reality, probably you had increased the dose of insulin, which the patient has interpreted as decreasing the dose, and that has led to a treatment error. So just phone call may be very easy, but it doesn't keep any record. Then specialized chat, telemedicine, smartphone, etc. Here, those shortcomings can be actually taken care of. The documentation and identification suitable for urgent cases. Again, no separate infrastructure is required. So WhatsApp is something good and can be real time. And WhatsApp actually is a good platform. You can share messages, and if needed, you can also do a WhatsApp chat. But then these have downsides too, like you cannot be sure of the identity of the doctor or the patient. This can definitely happen, especially if you do not know the doctor. There may be somebody who can impersonate as a Dr. Nilanjan Sengupta and give you advice. So it will be also important, so far as the patient is concerned, to be sure that the patient is talking to the right medical professional. And from the patient viewpoint, also theoretically, there may be a chance that somebody impersonates the patient now, but these are all theoretical possibilities. But for all practical purposes, if you are vigilant enough, this problem of impersonation should not be a problem, but you should be alert and vigilant about that, that both the doctor, both the healthcare provider and the patient, before engaging in a talk or in an interaction with the person concerned, should be sure that he or she is talking to the right person. And asynchronous email fax, that the most important thing is that for email nowadays, very few people are using fax. It is through email only. The most important advantage is that email, it is very convenient. Again, whosoever now uses the internet, even you can compose an email and send over a mobile phone. You do not think of about 10, 12 years back. Previously, if you didn't have a personal computer in the era before the era of smartphones, if you didn't have a personal computer, if you had to send email to somebody, you had to go to a place called cyber cafe. I think the cyber cafes have all but become extinct, at least in the urban areas. I don't know whether they are still present in the rural areas. So if you didn't have a personal computer at home, you had to go to the cyber cafe, you had to wait, enter, pay a fee, then get the machine, type the mail, and send it to the sender through a cyber cafe. And if the person is to receive a reply on that, maybe he had to again go to the cyber cafe next day to check his or her mail, whether he has received any reply or not. Nowadays, email has come to our fingertips. If we are using a laptop or desktop like myself, or even those who are using smartphones. So email has already become something which is very handy to receive, very handy to send, and also to attach reports, until and unless these are very big sizes like an X-ray picture or a CT or MRI. The ordinary reports can be scanned and sent via email also. So that is very important. Number two, you can preserve the document for the future, both for the patient and the healthcare provider, that I have sent you, if the doctor denies, you haven't sent me anything, you can say, I have sent you this reports yesterday at so and so time. Please have a check at your mail and get back to me. The same thing can happen if the patient tells doctor, I have mailed you my problems. I wanted your advice, but I didn't receive any reply from your end. You can just check your records and say, no, I had sent you a reply, say, yesterday at 3 p.m. You just go back and check your mails. So that is important, and you can have the records. That's very important. It is usually not a real-time interaction, but it can also be real-time. And just one-way context is available, not really so. It can be two-way if both the parties are privy to the email IDs, which it can be a two-way context. And non-verbal cues are missed. Of course, email is a non-verbal mode of communication, but that can be actually, nothing is a substitute to the other. It can be backed up with a verbal communication. What I do, so if the patient consults me, I say, doctor, I'm having this, having that, I'm not getting this medicine, that was your prescription. But what I tell, you scan my latest prescription, you scan the latest reports, you just jot down your problems, send me a mail. I will go through the mail. As I go through the mail, either I call back the patient or ask the patient to call me back. Then I ask one or two questions. Are you having this? Are you having that? And then I formulate my decision and type it out and give it to the patient. Because the greatest advantage is that here everything is in writing, so that you have a document. And since it is not a real-time one, it can be preserved in an inbox. If the patient has any query, he can go through the mail, can again get back to the doctor. I don't understand what you say. Please explain. So there is less chance of miscommunication. So I think if you are to use the email, that has to be backed up with phone. So that will make it even more useworthy. So guidelines for telemedicine in India, I think guidelines are being sent by Government of India, context, identification, mode of communication, consent, type of consultation, patient evaluation and management. I won't go into the details. They have made a list of group of drugs, 0, A, B. I'll come to that, what you can have it. Mode of consultation, video, audio, text, any. Nature of consultation, any. For a O group of drugs, these are like common drugs like paracetamol and so on. For A, you go for video. For B, you can this, and there would be certain drugs which should not be given by telemedicine. You can very well understand, maybe narcotics. So you cannot prescribe probably pethidine over telemedicine. That should not be so. So there would be many flow charts. Actually, I won't bore you with all these things because that you will have to customize how you best do patient audio, video, text, patient identification. So now if I tell for all of your patients, you go video consulting, that is going to fall flat because I have my patient pool. I know only about 5 to 10% of my patients would be able to participate with me in a video chat. So if I tell that I won't give you any advice until and unless you participate with me in a video chat with a prior fees being deposited online, then only 5% of my patients will be able to avail of my services because they simply do not have the physical infrastructure to be online. Not only, it doesn't mean that they are poor enough. There may be very wealthy, rich individuals living in the cities like Mumbai, Kolkata, Chennai, Delhi, and so on. But the persons may be one of 80 years of age and his wife may be of 75 years of age. They may not have the dexterity to learn video chat at this age and start conferencing with the doctor. So you have to customize what form, what communication of telemedicine will you use with different patients. For example, for a patient who is an IT professional, who is young, otherwise dynamic, is conversant with these technologies, for them, video conferencing is the best. For an elderly person who otherwise can talk well, is just a follow-up patient. There is no skin lesion or anything that you need to see. Just you have to review the reports or just have to address an emergency. Telephone is the best. Maybe that may be backed up with the documents being shared either by WhatsApp or an email. So the consent is an implied consent, but in certain telemedicine platform, especially in a well-organized telemedicine platform, you can also have a consent form there, which is signed, or you can ask the patient to check in the consent form. That would be, you can devise your own software like as you do in banking or in many other things. I agree, there are terms and conditions and you say, I agree. There you can have an informed consent and you can have that consent form, and that the patient, you may allow the patient to check that form. Otherwise, the consultation doesn't progress if you are that legally minded. In case appropriate management by telemedicine. Next, I was saying, first is what is the flow chart that I said. Now, you have to select which are the patients who are appropriate for telemedicine. I have given you an example. An young IT professional would be the most suitable patient for telemedicine. But an elderly couple staying alone would not be the ideal patient for teleconferencing, video conferencing. Similarly, what are the conditions? Like, as I given the example, hypoglycemia. or adjustment of insulin dosages. This can be done very well by way of telemedicine. Or even in a stable patient, the annual review for hypothyroidism can be done by way of telemedicine. I'm just giving a few examples. But if the patient has a fever, if the patient has a trauma to the knee, if a trauma to the lower extremity where you cannot assess whether it's a soft tissue injury or there's a fracture, or what is the degree of soft tissue injury, there a direct physical examination is absolutely necessary. That cannot be done just by showing a picture of the swollen limb, swollen joint, or a picture of the radiograph means nothing. You have to interpret the clinical condition in toto in light of the clinical findings, the investigations, and the examinations. So what I said, a simple hypoglycemia or a follow-up for a stable patient of type 2 diabetes or even of type 1 diabetes, a case of hypothyroidism on replacement, or even a treatment naive hypothyroid who is started on levothyroxine can be done by way of any form of telemedicine. An acute situation, even like a hypoglycemia, can be managed over telephone. A situation like, say, acute coronary syndrome or a fracture of the upper arm or the fracture, or a Colles fracture or an ankle fracture or an ankle sprain or some such thing, or a fever of undetermined, unknown origin cannot be addressed by telemedicine. For that, physical consultation is a must. So these are various flow charts. I won't go bother you with the flow charts. Medicine list, as this is when what is list 0, list A, list B, that you have to, if you really start practicing, you should be knowing what drugs you can prescribe over telemedicine and what not, especially if you are starting it for the first time. But the point remains, if you think a drug which has a narrow therapeutic window and that can cause harm, it is better not to start until and unless you are doubly sure. And for that, you may have to see the patient face to face. Prescription format, that entirely depends up to you how you devise the format. It's not that this is the best one. You can devise your own format according to you. You can also digitally sign if you know how to make a digital signature with your mouse, because that gives a sense of personal touch to your prescription. Or what you can also do, if you think that you would write your prescription with your own handwriting, which I think many of us are still adept at these days, rather than typing a prescription, you can write a prescription in your prescription pad, scan it, upload it, and send it to the patient through an appropriate transmission medium. So telemedicine and training during COVID-19 pandemic, there's nothing new. It is the COVID-19 pandemic and the lockdown that ensued because of this, the prevention from COVID, that has forced us to adopt some sort of telemedicine. That is why we are discussing, we can skip this slide. And for COVID treatment, how telemedicine can help, I think I'm not an expert on infectious diseases, but there are advisories by the government of India and the local state governments, even on telemedicine for tackling the COVID pandemic. You should go through them. So to conclude, telemedicine provides an opportunity to judiciously manage patients during this lockdown period. It is true, this is not, it is a poor substitute. I repeat, telemedicine remains a very poor substitute to the usual physical consultation that we have been used to doing since ages, that we, the doctors, were conversant with, and the patients also were conversant with. So telemedicine is only a poor substitute to it, but it is better than doing nothing. So if the patient cannot come, it's now about more than a month, and we do not know for how many more months we will have to be under lockdown. And even after the lockdown is lifted, taking those precautions to see patients physically, we have to curtail the number of patients that we can see physically. So there would be a big queue of patients, big waiting time. So that can be taken help of if we take help of telemedicine. Except a few instances where face-to-face consultation and hospitalization becomes necessary, it is good. But even when hospitalization becomes necessary, telemedicine can help. At least the advice that this patient, on listening to your complaints, appears to be ill, you rush this patient for hospital admission, is also an important advice that can be given to the patient by way of telemedicine, and thus can save the life of the patient. And of course, we are on the learning curve of telemedicine. As we adopt telemedicine, there would be we will make much mistakes. Not that these are deliberate mistakes. These do not, the patient shouldn't think that these mistakes are deliberate and intentional. Even the patients would be making mistakes. We have to be patient with the patients, because only the other day I asked the patient to WhatsApp his reports and the SMBG data. The way he WhatsApped me, I was not being able to at all understand that it was so indistinct, so blurred, that I was not able to opine on the reports. Then I wrote the patient once again, the images are indistinct. Please take proper images and send to me. So you have to be patient. You have to understand. I just thought that we are using the cam scanner, and we are using the WhatsApp left, right, and center. I do not know the patient sitting at the other end of the telemedicine spectrum. Or maybe that was the first photo that the patient is taking through his smartphone. So his photo quality may not be that good, or as per the standards, so that I can understand. So I didn't shout on the patient. I didn't rebuke the patient. I said that the image quality, the picture quality is not good. Please take good pictures. Otherwise, I won't be able to opine. So we have to, both the patients, either way, the patients and the doctors, we have to understand that telemedicine is a substitute to physical consultation. In these situations, we are forced to adopt telemedicine as a substitute to physical consultation where it works. It will not work in every patient. Sometimes the patients will have to come physically to the doctor or the hospital, but where it works, we have to be patient with our patients. They will be committing some unintentional mistakes. We have to guide them so that we can take out best of telemedicine. As healthcare professionals, we are healthcare professionals minded. We are not technology experts. We would also be faltering, and this would be maybe unintentional faltering. And especially if the patient happens to be a person proficient in information technology, they may try to find fault with us. They also should understand that doctors are also adapting to a new technology as per demands of the time, as per demands of the situation. They also should understand that all of us are on the learning curve, and we will try to give the best under the circumstances. Thank you very much for your patience. If there are any questions, I would be able to take, though I know that I'm not an expert on the field of telemedicine. I'm also learning as you are. Is it legal to provide online prescription those who are not serious? Again, I'm not a legal expert. That's the problem. I think it is legal. But you please, with a disclaimer, you please check it with a legal expert or a person expert in FMT, but I think it is legal. Professor Jayant Panda, role of ARBs and ACI in precipitating severe COVID disease. This is not our topic today. Our topic was on telemedicine, but still, Jayant Panda, how are you? I don't know. I hope you are fine. I think ARBs and S inhibitors should not be discontinued in COVID patients because of the theoretical, concept of ACE2 and the virus having ACE2 as a receptor and probable upregulation of ACE2. That's also probable, not confirmed with ACE inhibition or ARBs. So the bottom line is that generally we shouldn't deprive the patients of the benefits of ACE inhibitors and ARBs just for those theoretical concerns. From Dr. Da, how long should you keep record of your telemedicine? Again, I'm not a legal expert, I cannot say, but I think what is the time? I think for 2 years that you just check whatever you can keep. But yes, for telemedicine, record keeping is easier than when you are doing a chamber practice. So for EMR, for electronic medical record keeping, I think telemedicine is better. Can all type of diabetic products can be prescribed? I think yes. I think yes. Of course, you have to look for those advisories that I'm doing anyway. But I think that can be, but you have to be, so when you are prescribing SGLT2 inhibitor, you have to be doubly sure that you are not missing out anything. Is there any limit? I don't have any idea on that, whether there is any fee capping on fees. Now, I have a question which I've asked many people, I haven't not got the answer yet. So if my fees for a physical consultation, say, is rupees X, if I go for a telemedicine platform, charging fees, whether it should be equal to X or X minus something or X plus something, that I don't know, because ethically, if I'm not seeing the patient, I should not charge my full fees. At least that should be 70 to 80% of my what would have been my fees had I seen the patient physically. But again, somebody may argue, why shouldn't it be more? Because in these troubled times, I am taking help of a special technology to reach out to the patients, which is not, close to us. We are adapting, so why shouldn't we charge more? I do not have the answer. How can we use this telemedicine after COVID? If we learn, if we get used to it, we can always take the positive points of it even after COVID, because telemedicine is nothing new. In Australia, they have been using telemedicine to capture retinal photographs on distant areas and sending to a center to view the retinal photographs. And if there is everything all right, they say that, okay, you didn't come to a specialized center. And if there are suggestions of diabetic retinopathy, they call the patient for a physical examination. So that is there very much in Australia, much before the time of COVID. So telemedicine was there in the past, will be there in the future. Now you are hearing much of telemedicine because we are locked down, because we are afraid of infection. So I think telemedicine has been there very much in Australia so far as fundal photography is concerned. And in our institute, we have telemedicine sessions since long, and since last, at least since I have joined, we have telemedicine from SGPGI and from other centers. Dietitian telemedicine service has been there as a part of Sat service of Sanofi much before COVID. There, my dietitian of Sat advises the patient over phone, and finally she talks with the patient over phone and formulates a sample menu or a diet chart and sends the patient over mail. Again, that is a part of the SAT program of Sanofi. You can check with them, and that is there since the last 5, 6, 7 years, much before COVID. So dietitian telemedicine service has been in place. Again, I do feel that that is not the best. Direct interview of the patient with the dietitian is the best option. But when the patient cannot reach the dietitian, at least it is better than nothing. And many of our patients are very much happy, satisfied with the telemedicine dietitian service of SAT. The medico-legal side of telemedicine, now the government has probably approved. I think whatever you do over telemedicine, any form of the platform, you should try to be legally safe in having the disclaimer: if you have any problems, contact your nearest health facility. That is my word. Over distance is not the ultimate one. No matter how refined the technology is, this is there to help you, to aid you in times of stress. But emergency services, at least in the government sector, are all open, even through the period of lockdown. If you have any problems, if you do not understand anything, if you deteriorate, do not hesitate to physically attend the emergency health facility. That way, you at least would be legally safe. You should always tell the patient that I'm not the final answer over phone. I have my restrictions. I'm trying to help you. But if you have any problems, you consult a doctor physically. If you come to me, if I am available, you come to me, or go to the nearest health facility. Does it suitable for new patients? Ideally, no. But then we have to make it, rather than not seeing patients, this is better than doing nothing. How do you find your practice? I haven't not started it in a formal way, but in an informal way, this is the only option that we can fall back upon at the present time. And level of satisfaction, I'm not very much satisfied, but I feel the patients are satisfied. But then we have to compromise. This is a piece. Now I cannot go out and do my daily exercise. I'm not satisfied, but what to do? I have to be contented with whatever exercise I can do within the 4 walls of my 1,000 square feet flat. Hydroxychloroquine can lower blood sugar level. It has been approved by the Drug Controller of India as an add-on anti-diabetic agent. So it can lower the blood sugar level, definitely. Not much, not precipitous, but if you add hydroxychloroquine, you have to be vigilant about hypoglycemia. Yes, many companies now that would be the most business. Any comments on that? I have used only one. I have not yet started consultation, but you see for yourself, which is easy, where the data encryption is there. These issues would be there, but we are still on the learning curve. Even not me, if you can ask some of other colleagues, which one is the best? It is very difficult. It's still early days. Well, whichever suits you best, you do it. And it's not that you have to always use an app to do telemedicine. Just talking to the patient with phone, the exchanging messages or information over WhatsApp is same as telemedicine. It is telemedicine. How you will collect your payment, where you won't be pleased the patient does the consultation without paying you, that's entirely up to you. Which one you think that you won't be pleased, that's actually up to you. But then there is both sides to it. If you are not vigilant enough, the patient can take your services and not pay, and you cannot chase the patient. So I think it would be best to ensure that the patient in any platform, until and unless you see the patient's payment is credited, you won't do the consultation. But at the same time, if you ensure that too much in a chronic setting, I mean to say, in an acute setting, of course, you have to advise the patient, fees would be coming later. But in a chronic setting, but if you go too much on that, that the patient may think that you are actually a mercenary. So you have to be very cautious on that. Role of telemedicine in GNO illness. I understand why you asked this question. Mind it, neither am I a gynecologist, nor am a specialist on forensic medicine and toxicology. So I'm not the best person to answer on this. I'm an endocrinologist, but I would say that all diseases, all emergencies cannot be treated by telemedicine. There are limitations to it. If you think that without examining, because how can you actually follow up, say, advanced pregnancy or labor through telemedicine? The cardiotocograph being transmitted to you, you are sitting at home, and there is a deterioration, and then you intervene. I think that is absurd. You cannot do that. So obstetric practice is an emergency. I think their telemedicine ideally should not have much role. Of course, it may have a complementary role, like the patient has gone into labor, called you, and advance in third trimester, the patient calls you and you ask you understand that the patient has gone into labor. You can ask the patient to attend the hospital where the confinement would be there. So that is also telemedicine. That advising the patient, now go and get yourself admitted, probably because you have gone into labor, is also a telemedicine. So there have been quite a lot of questions, I think. That's all for now. Thank you very much. I didn't know whether it was informative to you or helpful to you, because I still give a disclaimer. I'm new to it, nor am I a legal expert, nor am I an expert on forensic medicine and toxicology, but I'm a simple endocrinologist. But I have rather talked much from my evidence and my perceptions rather than the legal point of it, which you are privy to it. You can always go through the records and make a judgment for yourself. Thank you. Thanks, Blue Tree and Ajanta Pharma, for facilitating this program. I now sign off.
Thank you so much, sir. Thank you so much. Thank you so much from Ajanta Pharma also. Ajanta Pharma being a top player in cardiovascular market, sir. We've been into innovative products and first time India products. And also I thanks all the delegates who are just logging in this crucial time. They've been busy into treating patient, but they have taken out some time to listen you, sir. And thank you to you also, sir. That's a wonderful session, and a lot of queries has been resolved, if I say from the delegates and from your point of view, sir. Thank you so much. My medical team is also Dr. Veena Venkatesh. He has supported in the presentation, and thanks to my field also, sir. They've been invited all the doctors across the country, and much more logins has been happened, and much more doctors has been attended. Thank you so much. Thank you so much, sir. Thank you so much. Have a good day, sir. Thank you so much.